The UK has recorded 174 coronavirus deaths in the latest figures, the highest daily rise in fatalities since March. The Department for Health and Social Care has confirmed a further 174 people had died within 28 days of testing positive for COVID-19 as of 9 a.m. on Tuesday. The figure represents the biggest daily spike in coronavirus deaths since March 12. There had also been a further 30,838 confirmed cases of COVID-19 in the UK. The increase in coronavirus deaths could force the government and experts to rethink the UK's COVID strategy heading into the autumn. Meanwhile, the latest weekly data shows there was 571 coronavirus-related deaths registered in England and Wales in the week ending August 13. The figures published by the Office for National Statistics (ONS) represent an 8% rise on the previous 7-day period. Separate data released by Public Health England on Tuesday suggests Cornwall, the Isles of Scilly, now have the highest rate of COVID-19 infections in England. A total of 4,430 new cases were recorded across the popular summer destination. In the 7 days to August 20, the equivalent of 769.7 cases per 100,000 people. This is up sharply from 384.0 per 100,000 in the previous 7 days. Meanwhile, a study has suggested a third booster jab may be required for the most vulnerable in society. A study by scientists at the universities of Glasgow and Birmingham suggested 2 in 5 people with an impaired immune systems have a low or undetectable antibody response after being double vaccinated. The research project compared the immune responses between 600 patients with immune-mediated inflammatory diseases and 231 healthy individuals after they had received both doses of either the AstraZeneca or Pfizer COVID-19 vaccines. Around 3 in 5 people in the vulnerable groups were found to have an antibody response similar to those found in healthy adults. But 40% have generated a low antibody response compared to healthy people. Trial lead, Professor Ian McInnes from the University of Glasgow, said the majority of the patients in the Octave trial actually have mounted an immune response that looks remarkably similar to a healthy control group. 60% or so of our people with these rather significant conditions are in fact looking effectively the same as people who are otherwise have an unimpaired immune system. This group who have the slightly lower levels of antibody response, we don't know what that clinical correlate is, and that's because our trial is not designed to see what does an antibody level mean for your likelihood of getting an infection or the seriousness of that infection should you become infected. I think the absence of an antibody response is probably not ideal. Asked whether the data supports a potential booster campaign, he added, "Our data suggests that a booster for people who have mounted either an absent or lower level of antibody response would be a very reasonable next step." Our view as a group of investigators is that the third inoculation would indeed be a reasonable approach. But we are only one part of the data set that will inform wider policy.